So it's not that Corona is how nervous system tries to address that form of this part. And so, can you guys hear me?
Yes.
Yes, we can.
All right, all right, great. Great. So welcome, guys. Biology. How was the class yesterday? Do you guys have any questions from yesterday? Would you like to ask any confusions, any areas to address? Okay. In the absence of any questions, let's continue. So basically, the next thing we're talking about energies. And one thing you need to know about energies is basically a code. So what I explained, it brings a very delicate code. And one thing that nature or God has to put in place is to ensure that the brain has a code, a protected code. And of course, the meninges has three derivatives. Okay, so the dura mater,
Hello? Hello, Dr. Ohis. Hello?
hello, okay, can you hear me?
Yes,
Hello,
your
can you
voice
hear
is
me?
little bit muffled. Your voice is muffled and there's some disturbance. Can you just please try to fix that?
Okay, can you hear me now?
Yes, it's better,
All
I
right,
guess,
great.
now.
All right. So, the dura mater itself is the thickest part of the meninges, and it is the part that is kind of closest to the skull. Meanwhile, the two other parts, the arachnoid mater and the pia maters, are derived from the neural crest cells. You know, I told you that the neural crest cells are like the nomadic part of the nervous system. They travel far and wide to various organs, and one of the derivatives of the neural crest cells is the arachnoid matter and the pia mater. Okay, and they're also combined together. They are known as the leptomeninges. Okay, so we need to know that. The CSF is between the arachnoid matter and the pia mater. It's very, very delicate. The arachnoid matter is given that name because it looks like a web. You know, when you do an autopsy, you see a patient, you do an autopsy of the brain and you look at it. When you reveal the arachnoid matter, it has this cobweb-like appearance, and that's why it's called the arachnoid matter. And so when you have a spinal cord, let me get a session for you guys to show you. Let me just draw this so that you can get what I'm trying to say. Just give me a minute. I want to draw this for you guys so that you can see what I'm talking about. Okay. So this is like let's say this is the dura mater, and then we have the arachnoid mater, and then we have the pia mater, right? So I will label here D, okay, and then I will label here A, standing for arachnoid matter, and then I'll label here as the pia mater, which is the innermost layer. And this is like the brain, the brain of the individual, you know. So more like a covering, permit my drawing. And so the CSF passes through here. So the fluid that comes here, it kind of like cushions the brain. It also acts like a media through which nutrients diffuses to the brain as well. And then these two together, these two is called the leptomeninges, and is derived from the neural crest cells. Okay, neural crest cells. Neural crest cells. Let me just write it like this so that we can get it. Okay, and so basically the epidural space is basically just the space above this, okay, or beneath this rather. Sorry. So this is the epidural space. Epidural space. Okay. So basically, when you look at the brain from this dimension, this is where the CSF is. It runs through the arachnoid matter and the PI matter, and the epidural space is just beneath the dura mater. And the dura mater is derived from the mesoderm. So let's write meso. Okay. So these are usually very high yield stuff that you're supposed to know. And let's go ahead. So we need to know that the epidural space is the point where blood collects when you have an epidural hemorrhage, okay? And one of the arteries that are involved in that injury there is the medial meningeal artery. Yeah, so this is also very high yield for you guys to know. It's right here. Okay, now the next thing we're going to talk about is the blood-brain barrier. And the basic thing you need to know is that the blood-brain barrier is like the channel through it's more like a protective channel that does not allow certain things to cross to the brain and allows certain things to cross to the brain. And it's made up of basically 4 things, okay, from our text here. And the most important part of it is actually these tight junctions. Who knows the other name for tight junctions? There's another name for tight junctions. Who knows what they call it? Or rather, who knows what is another name for tight junctions? Is anybody there?
Zona occludens.
Beautiful, beautiful. Zonal occludence is another name for tight junctions. And it's the most important part in this barrier because every other part here can does not place a large amount. This plays about 90% of the role. This forms 90% of the barrier. This is actually what makes the blood-brain barrier what it is, the tight junctions, okay? And then other parts are the basement membrane, the pericytes. The pericytes are like, how will I explain it? They're like extensions of the endothelial cells, right? And then the astrocyte food processes are gotten from the astrocytes, which are supporting cells. You know, I mentioned earlier on that the astrocytes are like supporting cells, and these are very, very important. So because it's the basement membrane is made up of lipids, it's only logical that lipid soluble substances cross very, very easily as against other polar substances such as glucose and amino acids. Okay, there are 4 regions that are not covered by the blood-brain barrier, and one of them is the area postranema, which is like the chemoreceptor trigger zone that helps with vomiting. Okay, and the other part is the OVLT, which is organum vasculosum lamina terminalis. These things act like osmochemoreceptors, basically. They help in the secretory aspect of ADH. Of course, we know what ADH does, helps with water secretion and impacts generally osmolality. Another thing we need to know again is known as the, there are four basic things that are there as well. And apart from the OVT and the area postranema, there are other two extra ones. And then the area postranema, the OVT are the ones I can remember right now. I can't really remember the remaining 2. There are 4 others. Can anybody help me with the remaining 2? Okay, yes. The subphonical organs. Great. Thank you, Dr. Axel. Can anybody know exactly the median eminence of the hypothalamus? That's excellent. So the 4 areas includes the OVLT, the area postranema, which is the chemoreceptor trigger zone, the median eminence of the hypothalamus, and the subphonical organ. Great, guys. Fantastic. Okay, so let's go down to the next part, which is the chemoreceptor trigger zone. Okay, so basically this is located in the medulla, right? And the high yield part you need to know here is where it's located. And then secondly, the drugs that work, the pharmacological implication of this. There are certain drugs that we use for patients who are vomiting in a way to try and, mitigate it. And most of them Of course, the high yield ones we need to know are the serotonin antagonists, D2 antagonists, the NK antagonists. They are used for chemo receptor induced vomiting, and the most common one we use are the 5H3. So these are like the common ones we use. And then there are other ones that we use, the histamine and muscarinic antagonists that we use in treating motion sickness. This is very high yield. So we need to know this as well, okay? All right, let's go to the next page. Yes, now we have sleep physiology. Now this is a very high yield topic in the exams. A lot of questions come out of it. And basically sleep physiology has to do with the circadian rhythm and what goes on when we are asleep. So basically there are two stages. We have the non-rapid eye movement, okay, and then we have the rapid eye movement, okay. And it's worthy of note that we spend more time in our REM sleep than our non-REM sleep, okay. And then the part of the hypothalamus that's responsible for that is the suprachiastic nucleus of the hypothalamus. Very, very important. You must know this is very high yield. And then melatonin also plays a significant role in this case from the pineal gland. So these are also very high yield things that we need to know. So we need to know the EEG. So when somebody's asleep and then you put an EEG on the person's head, you try to monitor the electrical activity of the brain, and you find some quite unique things that happen. Okay, and the first thing we need to know is that when the patient is awake, the most common wave that you encounter is the beta wave. When the patient's eyes are open, just like right now, you and I, we are looking at the system, we can observe that it's the beta wave. But however, when we are sleeping, the most predominant wave is the alpha wave, because our eyes are closed and we are not really in cognizance of what's happening around us. Okay, now in the non-REM sleep, we have 3 extra stages, and for some very weird reasons we spend a lot of time in the stage 3, which is the deepest form of sleep. So at this point here, these are the high yield things you need to know. Okay, so this is the stage where we bedwet. This is the stage where we sleepwalk. So usually in the exam they bring it as this: a patient was bedwetting, and they put an EEG for you, and they tell you what stage of the sleep physiology does this occur. Okay, right? So the most logical answer to that is N3. Then we need to know bruxism. Bruxism is another very important high yield concept that you need to know, and it occurs in stage 2. However, there's a mnemonics for this, right? There's a mnemonics for this, and I'm just going to share that with you. And the mnemonics is usually BAT, B-A-T, okay? And it's assumed that in the first stage, when you're awake, it's a beta wave and an alpha wave. And then stage 1, you have the theta wave. All these waves are not really high yield, but the most high yield thing you need to know about this are the conditions that are associated with these stages of sleep. You need to know that bruxism occurs in stage 2 of non-REM sleep. Bedwetting and sleepwalking, night terror occurs in stage 3. Very, very high yield. You people need to know that. Okay, now we go to the REM sleep. The REM sleep is a very important stage, right? And this is the stage when nightmare occurs. What is the difference with terror? The mnemonics for stage, the N3, is that the patient is so terrified that they can't sleep. The patient is so terrified that they can't sleep, and that usually occurs in stage 3. But nightmare, on the other hand, this thing is very tricky in the exam, and you need to know this. So nightmare occurs in REM sleep, while night terror occurs in non-REM sleep. This is a question that they use to trick students a lot, and you people need to know this. So it's very, very high yield. Okay. The next thing we're going to talk about various things that affect this. Okay. So I'm going to explain some terminologies.
Excuse me.
Yeah.
Could you repeat nightmare and night terror? Something you said, right?
Okay. So I'm saying that night terror, the mnemonics for it I used to remember night terror is that when you're in your non-rapid eye movement sleep, it is very easy to arouse you as when you are against your rapid eye movement, which is like the deepest form of sleep. You spend more time in your REM sleep as against your non-REM sleep, okay? So night terror is that the patient is so scared that the patient won't be able to sleep. So I correlate that, the fact that the patient is not able to sleep, with non-REM sleep, because that's like the lightest stage. That's the stage that you can easily arouse the patient or you can easily arouse the individual. So it's very tricky. What they do in the exam is that they will tell you that which of the following stages of sleep does night terror occur, and which of the following stages of sleep does nightmares occur. Okay, so between nightmare and night terror, it's assumed that night terror is more severe. Do you understand what I'm trying to say? And of course, it will wake the patient easily as against nightmare. So how I remember it, the mnemonics I use is that the patient is so terrified that the patient can't sleep. And of course, non-REM sleep is the stage where the patient is easily arousable. Okay, so REM, when the patient is in REM, what occurs is nightmare. When the patient is in non-REM sleep, stage 3, which is the deepest stage of non-REM sleep, the patient has night terror. Do you get the correlation? Hello,
Yes,
Doc, did
yes,
you get?
doc. Yes,
Okay,
yes, yes, doc. I got it. Thanks a lot.
no problem. So let's try and move on and get this. Now, there are certain things that affect sleep architecture. Usually, this comes out a lot in the exams, and I think in my step 1, I remember the question that came about this, but I think it was was it benzodiazepines? Yes. How the benzodiazepines, how does it affect the sleep physiology? That was the question that came out. So what happens here? It decreases the duration of stage 3 of non-REM sleep, and then it also decreases REM sleep. Okay. And that is why benzodiazepines are very useful for sleepwalking and sleep terror, because of course the patient is kind of awake but still in that sleepy state, and then you need something to sedate the patient. Okay, so it reduces the non-REM sleep and the non-REM sleep stage 3 and then the REM sleep. So basically what happens here is that you need to you spend a large amount of time in your REM sleep. Okay, and the point of giving a patient alcohol, benzodiazepine, and barbiturate is to try as much as possible to get them as fast as possible into the REM sleep. Okay, so what you do is that you shorten the duration of the stage 3 so that the patient can quickly go into the REM sleep and be sedated. Do you understand the logic? The logic with giving benzodiazepine is that you are reducing the amount of the stage 3, which is the deepest stage of the non-REM sleep, so that the patient can easily go into the REM stage of sleep and then spend more time there. Okay, that is how benzodiazepines are able to help with sedation, sleepwalk, and sleep terror. Okay, it's similar to what you have with aging, basically, but it's quite different in a way, because when you age, you spend less amount of time. So the total duration of sleep you have is less. Because as you age, because you spend less time in your REM sleep, because you spend less time in your REM sleep, not the other way around. Now you spend less time in your REM sleep, you get easily awakened in the morning. And that's why people who are older tend to have a very, how would I put it, a very limited amount of sleep. Okay. So these are the IU things you need to know for this. Almost similar, and then also this. Okay. But depression in its own way is quite the opposite of a lot of things. The REM latency is the duration between when the patient starts sleep and when he gets to the first REM cycle. So basically, let me draw this so that you can understand. Okay. So basically, let's assume this point to be REM sleep, right? And then let's assume this. So let me just write R. Let's call here REM, and then let's call here N3, which is the last stage of Okay, so the latency means that the duration it takes for you when you start sleeping, that's when you enter into the first stage of sleep, which is N1. So REM latency is just typically the duration between when you enter into sleep and the first cycle of REM, because when you are sleeping, you have multiple cycles of REM, multiple phases of REM. So the sleep latency is the duration between when you first enter into sleep to the first REM cycle you are going to have. This is known as sleep latency, or REM latency rather, sorry. REM sleep latency. The point is, for normal individuals, when you increase the latency, when you increase this sleep REM latency, it means that the duration between this point to this point is longer when you increase this latency. The opposite happens when you decrease the latency. The point to this point here becomes shorter when you decrease the latency. So from this point to this point here is shorter when you decrease the sleep REM latency. But when you increase it, it is longer. So basically, what they're just trying to say here is that in depression, the latency reduces. That means the time it takes for N1, it takes the time it takes from here and to get into your first stage of sleep is shorter. But the problem with depression is that they don't stay in that REM latency for a long time. Okay? And what happens? Because they don't stay in that REM latency for a long time, they are easily awakened, and hence they have repeated night awakenings. Do you guys get what I'm trying to say here? Do you understand what I'm trying to say, guys?
Yes.
Doc,
Can
I
you
didn't,
repeat?
I didn't understand that this REM
Okay.
latency part and long.
Okay, so let me go over it again with this diagram. Okay, so we have REM latency. REM latency simply means the duration it takes when you start sleeping from N1, which is non-rapid eye movements in sleep, to the first cycle. So when you are sleeping and you enter into the REM stage, you have multiple you have multiple rapid eye movements when you get to the stage. So you can have stage 1, and then sorry, just give me a minute. So this is the second stage, this is the third stage, and this is the fourth stage. So when you are sleeping, you enter into REM. So this stage, from this point to this point here, is like, let's say 90 seconds, right? 90 seconds. And then from this stage to this stage, it's supposed to be shorter. So as you are sleeping, this is supposed to be shorter. So let's say the next one is 45 minutes. And then the next one is supposed to be like 30 minutes. Okay. Now, what I'm trying to explain is that when you enter into sleep, the first stage is N1. From that point to the first REM you are going to have, that duration it takes is known as sleep REM latency. Do you guys understand what I'm trying to say? From the first point here, to this point here, the first stage of sleep, first stage of REM sleep, from this N1, which is the first stage of the non-rapid eye movement sleep, to the first stage of the rapid eye movement sleep, that duration of time is known as the sleep REM latency. And what happens is, the shorter this time is, the better. The shorter it takes from you to get from this point to this point is better. Okay? The time it takes for you to get here to this point is meant to be shorter. Now, in depression, which is what I'm trying to say here, in depression, that latency is reduced, meaning that they can easily get into this REM stage, right? They can easily get into the REM stage. But the problem is that when they get into this REM stage, because this duration is shorter, they can easily be awakened, because they don't stay so long in the REM stage. They return back to this stage because of the shorter duration of this point to this point. Are you guys getting what I'm trying to say? So because this, Can you get what I'm trying to say? Hello?
The second half, I'm not able to get, Doc. Can you repeat the second half from REM to NREM again?
Okay. So I'm trying to say that when you enter into sleep, the physiological thing that happens is that you enter into sleep from N1, which is the first stage of non-rapid sleep. You should enter into, it has a particular fixed duration from when you're supposed to leave here and you get into here. And when you get into here, the ideal thing is that you're supposed to spend more number of times in your REM sleep, meaning the first stage is supposed to be shorter than the second stage. The second stage is supposed to be shorter than the third stage. The third stage is supposed to be shorter than the fourth stage. Okay? Now, what happens in depression basically is that the duration it takes for them to get into from this point to this point here is shorter in depression. That's what I'm just trying to say. Okay, as against, and in the same thing, narcolepsy, the same thing happens in depression and narcolepsy. There's a short duration of REM latency. So easily, what I'm just trying to say is that the duration of time it takes them to get to this stage is shorter. The duration it takes them to get to the first cycle of the rapid eye movement is shorter. That's what that REM latency means. That's what this decreased REM latency means. Do you understand what I'm trying to say? And
Yes,
because this
yes,
REM
Doc.
latency is shorter, yes, because this REM latency is very short, means that they don't spend so much time in the REM latency, because when you're in REM, you are meant to sleep longer. When you are in REM, you are meant to sleep for a very long period of time, because we spend most of our time when we are sleeping in REM. Do you understand what I'm trying to say? Because they don't spend so much time in the REM in the rapid eye movement of sleep, they are easily awakened. That's why they have that repeated nighttime awakening. Do you get what I'm trying to say? Do you understand what I just said?
Yes, Doc. Yes, yes.
Okay.
Yeah, so basically they get into REM sleep very easily, and so they quickly they get out also very easily. The
Beautiful.
latency
Beautiful. That's
decreases.
exactly summary of what I'm trying to say.
Yes.
All right.
Doctor, is the REM latency and the sleep onset latency the same, or is it different concept?
No, it's
The
a different
increase-
concept.
Okay.
It's a different
So
concept. It's a different.
what is the sleep onset latency?
Okay,
And then
sleep
what-
onset latency is from this point. Now, let me use here as this diagram as an example. So you can see that sleep onset latency is actually the stage between when the patient is awake to the first stage of non-REM sleep. So the time it takes for the individual while he's awake to enter into the first stage of non-REM sleep is what we call sleep onset latency. Do you understand?
Yeah, thank you.
Yeah. Okay. Okay.
And doctor, I also have a
Yeah.
doubt regarding the duration which you have mentioned, 90 minutes to 45 minutes. So,
Yeah.
from REM first stage is going to other stage, like which stage is he going? I don't
Okay. So
understand the duration part.
basically, okay. So this duration means that, okay, what I'm just trying to explain here, right, is that, let's say, for example, the first stage of REM takes about 90 seconds for the patient to achieve it, right? The next stage of REM, meaning that the patient is supposed to go into REM sleep, the next stage of REM sleep in a shorter distance, but we spend a longer time in REM sleep. What do I mean? If it takes 90 minutes for the patient to get from stage 1 to stage 2, he's going to spend like maybe 1 hour here. Let's say 1 hour, right? But the next time the patient is getting out of REM sleep, right? If the patient wants to go into another cycle of REM sleep, he will not spend that same 90 seconds. The patient will rather spend 45 seconds. Do you understand what I'm trying to say? But the duration the patient will stay in REM as it progresses is now longer. Let me just draw what I'm trying to say, okay? So let's say,
So the REM also has different stages.
yes, it has different stages. Yeah,
Oh,
we don't
okay.
call them stages. We don't call them stages. We call them cycle. Let me use the right word. It's called cycle, not stages. It's called cycle. Okay. So basically, when the patient gets to this stage here, right? Let's say the patient spends 1 hour. Let's say the patient spends 1 hour here, right? in this stage. It will take the patient, before the patient enters into another REM circle. So the patient, before the patient enters into another REM circles, let's say circle 2 here, it will take about 90 minutes, okay? But the patient will now spend 2 hours here in this REM sleep. And then when he wants to now get to the third cycle, instead of taking 90 minutes, it will take 45 minutes, but he will spend longer here, let's say 3 hours. Do you understand what I'm trying to say now? And then when he wants to get into the fourth cycle, the same thing, instead of spending, let's say 45 minutes, he will spend like 30 minutes to get into the next cycle, but to spend a longer hour here. Do you understand what I'm trying to say?
Yes, thank you.
Yeah. Okay, so let's move to the next. Are there any other questions here? Are there any other questions? Okay, so the next thing we're going to talk about is the hypothalamus. Okay, so this is a beautiful mnemonics, 10 hearts. This represents the basic physiological function that the hypothalamus oversees. And there are various nuclei that are responsible for this. These nuclei are very high yield. Okay, so how I remember the lateral nuclei is that the patient is awake for a late night snack. So late. Okay. So the first 4 letters. Okay, so the first 4 letters, LATE, is late. So when you want to take a late night snack, it means that you're hungry. Okay, so the lateral nuclei stimulates hunger basically. Okay. So how I remember it is that the lateral nuclei stimulates a late night snack. Okay, meaning that the patient is hungry. Do you understand what I'm trying to say? Like that's how I remember these things to make it a bit more easy to remember, okay? And it's usually inhibited by leptin. You know, leptin is secreted by fat cells, right? You know, leptin is secreted by fat cells. Are you guys aware?
Yes, adipose
Okay.
tissues.
Yes.
From adipose tissues.
Exactly. Yeah, so the
Ghrelin
more
from stomach and leptin from the fat tissues.
Yeah, great. Yeah, great. So basically, what happens here is that when you are fat, of course, you will not want to be eating so much. So the fat secretes leptin to try to modulate the lateral nuclei. Do you get what I'm trying to say? So that's how I'm able to put it together to make it all stick, to make the concept stick more better. Okay. And then the next nuclei is the ventromedial nuclei. Okay. And then what this does for you is just that it makes you, satiated, makes you in a state where you're not hungry, you're in a state where you're satisfied with the amount of food you are eating. And so you need to know what happens when each of these nuclei are destroyed. Of course, when the lateral nuclei is destroyed, the patient has anorexia, meaning the patient doesn't want to eat. And this is in comparison to the ventromedial nuclei. When that particular nuclei is destroyed, the patient tends to have hyperphagia. Now, does any of you know a particular syndrome in the neurological system that presents with hyperphagia? A very, very common syndrome that the patient has this hyperphagia. Other part of the syndrome is hyperarousal.
Prader-Willi syndrome.
Sorry?
Clover-Mackey syndrome.
Yeah, excellent. That's great. That's great, Doc. That's a great. Yeah, great. So the patient has hyperorality, has hyperphagia. Okay, so that's very good, Doc. That's very good, Doc. Okay, and then the arterial nuclei is responsible for the parasympathetic overdrive, and it helps with cooling as well. So this is the major thing. So the mnemonics is AC. So you remember the anterior nuclei helps to cool, and then the posterior nuclei helps with heating. Okay. And what happens is that if it's destroyed, if this particular nucleus is destroyed, the patient becomes very hot. If this particular nucleus is destroyed. So how I remember this particular one, the posterior nucleus, is that the patient, once the posterior nucleus is destroyed, the patient becomes cold-blooded. Do you get the understand? So the posterior nuclei being destroyed makes a patient poikilothermic. And the word poikilothermic means cold-blooded. Okay? So that's how I'm able to remember it and make the concept stick. Okay? Now, this one was the one we talked about in sleep physiology, okay? Where the patient, the patient is not able to modulate his sleep-wake cycle, okay? So a damage to the suprachiastic nuclei causes a disruption of the circadian rhythm, okay? And then the other nucleus we have to know is the supraoptic and the paraventricular, okay? And these are responsible for ADH and oxytocin. It's pretty much straightforward. The preoptic nucleus is chiefly responsible for thermoregulation and sexual behavior, okay? Now, what is the high yield thing you need to know about this? So failure of this leads to Kalman syndrome. How many of you guys know what Kalman syndrome is?
Amenorrhea.
Anosmia with the hypogonadism.
Anosmia.
Cannot
Yeah.
smell and just.
Great. So that's a very high yield concept that you guys need to know. Very, very high yield. Kalman syndrome. The patient presents with an anosmia. The patient can't smell and then has a sex disorder, which entails amenorrhea. The patient can't conceive, you know, and all of that. Okay. So we go to the thalamus now. What is the major function of the thalamus? How many of you guys know the major function of the thalamus? What's the major function of the thalamus?
Sensory.
Sensory
It
input.
receives all the inputs from the sensory.
Yeah,
All
so
over
it acts like a motherboard. Yeah, it acts like a motherboard.
Factory.
Yeah, great. It acts like a motherboard that helps to modulate the kind of sensory information that comes to the brain. Okay, the only sense organ that is not that the thalamus does not kind of oversee is olfaction. That's smell. But every other sensory information is modulated by the hypothalamus. Okay, and then you need to know each and every one of them. Although the most high yield ones are the lateral geniculate nuclei and the medial geniculate nuclei. Okay, the medial geniculate nuclei is responsible for auditory stimulus, and then the lateral geniculate nucleus is responsible for vision. Okay, these are the most high yield nuclei that you guys have to know. An injury to each of them, what happens? These are things that you also have to be aware of. Okay. Now, the limbic system. What does the limbic system do? The limbic system is characterized as a collection of neural structures that is responsible for various functions. Has to do with sex, has to do with emotions, has to do with satiety, has to do with flight. You know, basically it modulates behavioral discretions. Okay, and there are 5 basic nuclei, or there are 5 basic parts of it that you need to know: the hippocampus, the amygdala, and the mammillary body. Now, a disruption of this mammillary body leads to what syndrome? How many of you guys know what this syndrome causes? Where there's a disruption of the mammillary body in alcoholics.
When it is
Great, excellent. So that's also very high yield. You need to know this, of course. And then you know the amygdala is responsible for memory. Okay, very, very high yield. It's a part of it that's responsible for memory. Okay, and then we also need to dive into the part of dopamine. Okay, dopaminergic pathways, and we need to know which part is affected. Okay, so we have 4 parts that are basically affected. The tuberal infundibular pathway is what happens when somebody takes an antipsychotic and the patient starts having secretions from their breasts, especially in females. They'll start having galactorrhea, right? And we need to know that it affects the prolactin secretion. This is very high yield. So they usually bring the question in such a way that the patient commences maybe haloperidol, for example, or a typical antipsychotic, and then 2 weeks later the patient starts having galactorrhea, and they will now put the options: which of the following dopamine pathways affected? They will list the mesocortical, they list the mesolimbic. Of course, you know that the answer is tuberal infundibular. Okay. Now, this is a part of when you give antipsychotics. This is a part that these 2 parts are very high yield in terms of antipsychotics and how they work. Okay. This part is more like a reward part. Okay. And then the mesolimbic system is the one that is usually affected when a patient has schizophrenia and then the patient has positive symptoms. Can anyone list some positive symptoms that schizophrenics have? What are the positive symptoms?
Thought insertion.
Okay.
Lord, yeah.
Okay. What about the negative symptoms? Disorganized actions. Okay.
Mm,
Okay. Anhedonia. Beautiful. Beautiful. That's great. That's great. Okay. So the mesocortical system is the one that's responsible for the negative symptoms. Okay. So basically, the patient has anhedonia, flat affect. Okay. Suicidal ideation. So when we give antipsychotics, what we try to do is to try to limit, the amount of mesocortical activity. So basically, the typical antipsychotics majorly affect the mesolimbic areas. So the typical ones are the ones that affect the positive symptoms, such as hallucinations, disorganized thoughts, delusions. And then the atypical ones are the ones that affect both the mesocortical as well as the mesolimbic. Okay. Right. So this is just a diagram that shows the other parts. Now, I want to ask you guys, which particular neurotransmitter is secreted by the nucleus accumbens? What particular neurotransmitters is secreted by this?
GABA.
GABA. Beautiful. Beautiful. What about the ventral tegmental area? Does anybody know?
Dopamine.
Dopamine. Excellent. Dopamine. Great. Dopamine is secreted by the ventral tegmental area and the substantia nigra. Yeah, so that's correct. Okay. Thank you, Doc. So let's move to the next page. Are there any questions here?
Doc, is there any mnemonic for this one? What nucleus gives what?
Okay, so what I usually use to remember the positive symptoms is how many of you guys know what a limbo is? Like a limbo, when you go and dance in a karaoke and all that, right? Do you remember what happens there? Where you dance, you're being disorganized, you're dancing, you're scattering yourself. So basically, how I remember the mesolimbic pathway is that I just remember what a limbo is. When you go to a karaoke and you're dancing with a limbo, you're kind of like disorganized, you're not yourself. When you're dancing, you're not really organized, you're just shaking all parts of your body, more like you're responding to something. That's how I remember it basically. That's like a kind of like a situation that I use to remember it. Okay, I think that's the major mnemonics that I have here. Does anyone have any fantastic mnemonics to share? Does anyone have any fantastic mnemonics to share?
Doctor, what you said about the GABA?
Okay, so what I said about the mesolimbic system is if you go into a karaoke night, a karaoke night is like a dance hall night. Like you go to a party, for example. There's something known as a limbo. Limbo is like another word for dance, like when you're dancing. Do you understand what I'm trying to say? So you only do that when you're like happy, overexcited, or you're, when like I correlate it to like, you're having disorganized behavior and all that, more like aggressive behaviors. Do you understand what I'm trying to say? Like you are dancing, you are moving your body, you are shaking your body. So I picture the positive symptoms of schizophrenia with the mesolimbo system. So I use it like mesolimbo system. Do you understand what I'm trying to say? The mesolimbo pathway, like the limbo is like you're dancing, you're shaking your body, you're having disorganized movements. That's how I remember this particular mesolimbic pathway and its associations. Do you understand what I'm trying to say?
Got it, Doc.
Yeah.
Yes, doctor. And what about the GABA? Which nucleus secretes GABA? Something you
Okay, yeah. So the nucleus accumbens. I'm sorry, I'm pronouncing it wrongly. The nucleus accumbens. This so GABA is secreted by. Okay, so that was the question I was asking the doc. That's so GABA. Okay. Of course, you guys know that there are 3 types of GABA receptors. We have A, right? We have B, and we have C. Okay, A and B are the ones that are mostly found in the brain. Okay, and this is secreted by the nucleus accumbens, so Na. Okay. All right. Do we have any questions again? Okay, so the next thing we're going to talk about is the cerebellum, okay? And of course, you know, I drew this diagram the last time I was talking about the posterior fossa malformations, and I talked about where the vermis is, and where I talked about the tonsils as an extension of the vermis, and this is what I was trying to illustrate the other day. You can see that as an anatomical variation, that the only thing that goes through the foramen magnum is the spinal cord, right? But in the anodocari malformation, you can see that this place extends into the what do you call it? It extends into the foramen magnum, okay? And that's what I was trying to highlight, okay? But you can see the doctor asked in the last class about where the tonsils are and where they're supposed to be. And you can see that the tonsils is within this space, which is the posterior fossa, okay? And then we need to understand that the cerebellum is responsible for one only function, to coordinate balance, okay? And then what we need to know is that the vermis, the medial cerebellum, that's this part of the cerebellum here, this part here, is responsible for proximal limb musculature bilaterally. And then the lateral aspect is what is responsible for the extremities. So you can tell where a lesion affects in the cerebellum by the presentation. So if a patient is having limb ataxia, okay, is having limb ataxia, you most likely, or you have lower limb ataxia, you know that the patient is having something that has to do with the lateral cerebellum. That's more of the hemispheres, okay? But if the patient is having truncal ataxia, you know that it has to do with the vermis and the medial structures, okay? But the most important thing we need to know here are these nuclei, okay? The nuclei, what do we mean by these nuclei? There are 4 particular nuclei that are responsible for modulating movements. And from the lateral to the medial side, we have the dentate, the emboliform, the globus, and the fastigial, okay? And the mnemonics is don't eat greasy food. And we're taking this from the lateral to the medial. That means from the cerebral hemispheres towards the vermis, okay? And when you have problems that affect the cerebellum, there are ways to test for it. And one of the things you can do is to do a finger nose test, okay? When you're doing your neurological exams, you're clerking a patient, and you tell the patient to point to his nose, or you do something like this. You tell the patient, you put the patient's hands here, and you tell the patient to point towards your nose. So the patient, what the patient does is that he passes when he wants to get to the nose, because when there's cerebral affectation, instead of going directly to the nose, the patient points to the side. So he does something like this. Instead of going to the tip of the nose, he does something like this. Okay? And then you know that the cerebellum is affected. And also, patients that have intention tremors. Intention tremors are tremors that occur when the patient wants to carry out an action. For example, I want to reach out to the screen, and then I start having the tremors. Those are intention tremors, and they're usually affected in patients with cerebellar disorder. Okay. Are there any other questions as regards this? These are the high yield things you need to know in this particular area. Any questions? Okay, so let's go ahead. Yes, so now we talk about the basal ganglia. This is a very interesting topic. The basal ganglia is very important in voluntary movements, okay, and adjusting postures, okay? And then you need to know these 2 parts. On the diagram here, I wish I could draw this, but I think the first aid has done a great job here, okay? So the striatum is made up of the putamen and the caudate nucleus, okay? So this is the caudate nucleus, and this is the putamen, okay? And so the caudate nucleus is chiefly responsible for cognition, and then the putamen is responsible for voluntary movements, okay? And then there's a space here. This space here is known as the internal capsule. This is also responsible for modulating movements in patients as well. And then what happens is that the impulses from the cortex goes through these parts to help to modulate various movements that the patient wants to do. And then in patients that have Wilson disease, this part of the brain of the basal ganglia is affected. In this part, which disease condition affects this part, the striatum? Which disease condition affects the striatum? Does anyone know?
The Wilson's and the Par Parkinson.
Parkinson disease.
Parkinson's disease, beautiful. Huntington's disease, beautiful. Affects the heart, yes, beautiful. Great, guys. Now, there are two ways that the basal ganglia modulates movement. And one of the pathways is known as the direct and the indirect. So let me explain what happens here so that you guys have an idea, okay? Let me clean this and... Okay. So, for the direct pathway, the direct. So let me write DP. What happens is that there are impulses from the cortex, okay? So the cortex sends impulses to the striatum, which is S, okay? And these are excitatory stimulus, okay? Excitatory. Now, what does the striatum do? The striatum affects two parts. It affects the globus pallidum and it affects the GPE and what? The GPI. Okay. Now, for the direct pathway, what the striatum does is that it sends inhibitory impulses. So let me put I. Inhibit. It sends inhibitory impulse to the globus pallidum interna. Okay. And then what this does is that normally the globus pallidus interna sends inhibitory signals to the thalamus. And I told you that the thalamus is like a motherboard. It modulates all sensory and motor functions. And then what does this inhibition of the globus pallidus does? Globus pallidus interna. It causes an inhibition of this globus pallidus. Thus, this globus pallidus will not be able to inhibit the thalamus. So the signal is cut short here. And then the thalamus will now have more excitatory. Because this is inhibiting this will not be able to inhibit the thalamus. And thus, instead of having inhibitory signals from the thalamus, you'll be having stimulatory stimuluses. Stimulatory stimulus. Let's go over it again. Signals come from the cortex in the direct pathway. Signals come from the cortex to the striatum. What does the striatum do? The striatum's basic function is meant to inhibit this. Okay? It's meant. So it inhibits the globus pallidus interna. And the function of the globus pallidus interna is to send inhibitory signals to the thalamus. But when you inhibit the globus pallidus interna, instead of sending inhibitory signals to the thalamus, what will happen is that the thalamus will be more stimulated. So the thalamus will perform its function more. Okay? Now, you will understand this more when we get to the indirect pathway. In the indirect pathway, what happens? In the indirect pathway, what happens here is that the same thing, exactly the same thing. Let me use a yellow marker. So the cortex sends signals to the striatum. Okay? And what does the striatum do? Instead of the striatum sending signals to the GPI, it sends signals. This signal, this one here is excitatory. So let me mark here with E. Okay? So instead of sending signals, inhibitory signals to the GPI, it sends inhibitory signals to the GPE. That's the globus pallidus externa. Now, what does this thing do? When it sends signals to this point, this now sends inhibitory signals to the subthalamic nuclei. Okay? And then what does the subthalamic nuclei do? The subthalamic nuclei is ideally meant to inhibit the GPI. So here it's meant to be inhibitory. So when it inhibits the GPI, what does it mean? The GPI will not be able to send inhibitory signals to the thalamus, right? So what does it mean? It will stimulate, because this one is being inhibited. Because this one is being inhibited here, what now happens? There will be no inhibitory signals to the GPI. So what will now happen? It means that the GPI will be stimulated. And what will the GPI now do? The GPI, because the GPI is now stimulated, it will now send more inhibitory signals to the thalamus. And when you inhibit the thalamus, it means that less stimulus will be coming from the thalamus. So basically, they are the same pathway, but one is actually longer. So let's go over it again so we can understand. In the direct pathway, the cortex sends excitatory signals to the striatum. Now, the striatum itself has two functions. It can either send inhibitory signals to the GPE or send inhibitory signals to the GPI. The direct pathway means that the striatum, because it has been excited by the cortex, will send inhibitory signals to the GPI. And when you inhibit the GPI, what happens? There'll be more stimulatory stimuli to the thalamus. And then the thalamus will now be sending more inputs to other sensory, surrounding sensory structures, okay? But what happens in the indirect pathway? In the indirect pathway, is the same thing that happens to this point. The cortex sends excitatory signals to the striatum. And then the striatum here will now be excited enough, and it will now send inhibitory signals to the GPE, the globus pallidum externa. And then this globus pallidum externa will now send inhibitory signals to the subthalamic nuclei. And the function of the subthalamic nuclei is to send inhibitory signals to the GPI. However, because the GPE has inhibited the subthalamic nuclei, this GPI will not be receiving any inhibition. So it means that the GPI is now free to send more inhibitory signals to the thalamus. And so the thalamus will have less. So here, let's put less. Less import to other neurological structures, okay? And that is basically what is happening here in the direct and indirect pathway. Do we have any question about this, or do you want me to go over it again?
Please go over again.
Okay. So let's start with this picture here so that we can understand, okay? The first thing we need to understand is that the motor cortex for the direct pathway, this is the direct pathway. So the direct pathway, the motor cortex sends excitatory signals to the striatum, okay? Excitatory signals. So it sends excitatory signals, meaning it's stimulating the striatum, okay? When the striatum is excited in the direct pathway, what the striatum will do is that it will now send inhibitory signals. So you can see what I'm trying to tell you now. The striatum sends inhibitory signals to the GPI, the globus pallidus interna. And what this does is that when this is inhibited, okay, this will now be unable to send inhibitory signals to the thalamus. Because the GPI has been inhibited here, it means that it will not be able to send inhibitory signals to the thalamus. The basic function of the GPI is that it's supposed to send inhibitory signals to the thalamus. However, if you inhibit the GPI, what happens to the thalamus? It means that the thalamus will not be receiving inhibitory signals again. Instead, it will be excited. It will be excited to do more work. And that's what this diagram I was trying to explain is trying to say. The cortex sends excitatory signals to the striatum in the direct pathway. It sends excitatory signals to the striatum. However, the job of the striatum, its basic job is that it either modulates the GPE or it modulates the GPI, meaning it can send any signal to both. But when it is using the direct pathway, the striatum sends inhibitory signals to the GPI. The physiological function of the GPI is that it will send inhibitory signals to the thalamus. That is the physiological function. But when the striatum sends inhibitory signals to the GPI, it means that the GPI will not be able to carry out its original function, which is to send inhibitory signals to the thalamus. Rather, because there is no inhibitory signals coming from the GPI, because the striatum has sent inhibitory signals to this, meaning that the inhibitory signals that has been sent here will not enable this GPI to send inhibitory signals to this. Meaning that instead of the thalamus being inhibited, it will be stimulated. So S inhibits GPI. And because GPI is inhibited, it will not be able to inhibit T. So what now happens? Instead of T being inhibited, T will now be overstimulated. That is for the direct. For the indirect, what happens is that it takes a longer route and it has an opposite effect on the thalamus. What happens here in the indirect is that the cortex sends the same stimulatory impulse to the striatum. But what does the striatum do? The striatum will not send inhibitory signals to this GPE. These inhibitory signals means that the GPE will not be able to function on a physiological basis. Okay? Meaning that the physiological function of the GPE is to send inhibitory stimuli to the subthalamic nuclei. Meaning that if you inhibit the GPE, it means that the subthalamic nuclei will no longer be inhibited. And what will it do? It will now send stimulatory impulses to the GPI. And when you stimulate the GPI, it means that you are telling the GPI to continue working, to increase its pace, to work more. And the physiological function of the GPI is that it's physiologically meant to inhibit the thalamus. And when you now tell that GPI, okay, I've given you the go-ahead, do your work, I've given you a stimulatory go-ahead, continue inhibiting the thalamus, what will happen to the thalamus? Instead of the thalamus being stimulated, it will now be inhibited. Do you people understand what I'm trying to say? It now means that the thalamus in the indirect pathway has less impulse being relayed to the cortex as against the direct pathway. Are we understanding this at all? Or should I explain further again? Hello, guys.
It's clear.
Very clear now. So the summary, let's go over it again so that we can understand it. I don't want us to confuse this thing again. It's very simple. We have the cortex. The cortex is on the cerebral hemispheres, okay? And then the cortex sends excitatory signals to the striatum. The striatum includes the putamen and the caudate nuclei, sends impulses to them, okay? Now, what the striatum does is that it sends inhibitory signals to the globus pallidus, whether the internal or the external. In the direct pathway, when it sends that inhibitory signals to the GPI, it is telling the GPI that, look, your physiological function, which is to inhibit the thalamus, I want you to stop it. And so the globus pallidus internal will stop it. And when the globus pallidus internal stop its inhibitory function to the thalamus, it means that the thalamus is now free to do whatever it likes. And so it will be sending all the signals it can to the cortex back or any other neurological structure. Exactly. So the indirect is inhibition plus excitation. Similarly, yes, beautiful. Okay, beautiful. But the indirect pathway is quite long and it does the opposite. So what the cortex does is that it sends the same stimulatory signals to the striatum. And what the striatum now does is that instead of sending signals to the GPI, it will send it to the GPE, which is an inhibitory signal, telling the GPE that, look, that function you are doing, which is sending inhibitory signals to the subthalamic nucleus, I want you to stop it. And then the subthalamic nucleus will say, okay, yes, I've heard you. You have told me to stop. I'm going to stop. The subthalamic nuclei, its basic function is that it's meant to send inhibitory signals to the GPI. But because the GPE has told the subthalamic nucleus, don't send any inhibitory signals to the GPI, the subthalamic nucleus will fold its hand and say, okay, I'm not going to do anything again. And then the GPI will take off from there. What would the GPI do? The GPI will not see it as, okay, now you have told me not to inhibit. So it means that I can do my function properly, right? It will not stimulate the GPI to say, okay, GPI, my basic function is to inhibit the thalamus. And then it will send more inhibitory signals to the thalamus. And such, the thalamus will not be able to send more signals to the cortex. Do you guys understand it? Okay, great. So let's go on. Now, the cerebral cortex region, we have certain regions that we need to know, okay? This part of the brain is the Broca's area, okay? And this part is found, part is found in the parietal region, if I'm not mistaken. Okay. The Broca's area is responsible for production of speech, meaning you are able to control your muscles, and then you are able to articulate. And if the Broca area is affected, the patient has what we call expressive aphasia. So the patient is not able to articulate properly, okay? So the patient is not able to produce speech as it should be. The frontal lobe itself has, of course, the brain is divided into various areas, okay? And then we have the frontal lobe, we have the temporal lobe, occipital lobe, and we have the parietal lobe, okay? And then in the frontal lobe, we have 4 parts. We have the frontal eye field that controls conjugate movements. And we have the prefrontal cortex that affects behavior, memories, and other things like that. We have the premotor cortex that's responsible for movements, upper limb, lower limb, and all that. And then we have the Broca area that's responsible for speech. And then in this part here, we have the primary motor cortex that's separated from the primary somatosensory cortex by a sulci, more like a depression, known as the central sulci, okay? So the thalamus relays all its information to this part, the primary somatosensory, okay? That's where the thalamus sends all its signals to, okay? And then the visual cortex, which is the primary visual cortex here, is where all the signals from the lateral geniculate nuclei comes to, okay? And then we have the primary auditory cortex where all the signals from the medial geniculate nuclei comes to from the thalamus. Now we have the Wernicke's area here that's responsible for fluency of speech. So the patient is talking, but you can't really understand. Comprehension is not really there, okay? You can't comprehend what the patient is saying. The patient is just saying jargons, just saying so many things. And we call it fluent aphasia. Another word for it is fluent aphasia. And then we have the arcuate fasciculus that connects these two regions, okay? And this part is responsible for language comprehension and language production. Okay. This part here, once it's affected, causes global aphasia, the nucleus acute fasciculus. Okay. The limbic area is the part that is responsible for those 5 things I mentioned: fight, flee, sex, and all those things. Okay. That has the hippocampus, the amygdala, the mammillary bodies. This is where all of them are located. Okay. Also, this is the cerebellum, and then we have the pons and we have the medulla. Okay. The functions of these areas are what you need to know for the exams. I think that's what we need to understand there. The next part we're going to go to is the cerebral perfusion. And why is this important? Why is this important? This is why it's important, the Cushing's reflex. Okay? So we need to know that there's a formula for this, and this is the formula: cerebral perfusion pressure. So what happens basically is that when you increase the ICP, is the pressure in the intracranial space. So when you have an hematoma, when you have a tumor, what happens to the ICP? The ICP goes up. Okay? And when the ICP goes up, it means that it is greater than the CPP, which is the cerebral perfusion pressure. Okay? And if that happens, it means that the brain won't get enough blood supply because of the reduction in the CPP. So it's assumed that when the ICP goes up, the CCP reduces. So it's more like an indirect relationship. Okay? It's an indirect relationship. Now, there's something known as therapeutic ventilation. I must emphasize this because even in our day-to-day job as doctors, it's something that we utilize. So it is assumed that the brain's autoregulation is chiefly driven by the partial pressure of carbon dioxide. Okay? And what it means is that if you reduce the partial pressure of carbon dioxide, it leads to vasoconstriction. And vasoconstriction is not good for the cerebral blood flow. So if you want to reduce the ICP in the brain, all you just have to do is to increase the respiratory rate of the patient, because vasoconstriction leads to reduced cerebral blood flow, and that also reduces the ICP. Okay? So it's assumed that the cerebral blood flow is directly proportional to the intracranial pressure. So from this graph here, we can see that the cerebral blood flow takes a direct relationship. You can see that as you're increasing the cerebral blood flow, the partial pressure of carbon dioxide is also going up. Okay? Now, the only time that there is no cerebral perfusion is when the patient is brain dead. And of course, there are certain reflexes you must check. One of the ways to check for a patient is brain dead is via brainstem reflexes. So when you do the apnea test, you do the brainstem reflexes, and the patient is not responsive, you can say that the patient categorically is brain dead. So what do we need to take from this particular part is carbon dioxide. The partial pressure of carbon dioxide is chiefly responsible for the autoregulation. It modulates it. That's the first thing we need to know. And then we need to know that the intracranial pressure is inversely proportional to the cerebral perfusion pressure. And we need to know the Cushing's reflex, which is very high yield. It comes out a lot. It's a triad of hypertension. The patient has hypertension, bradycardic, and the patient has reduced respiration or respiratory rate. Okay? And then therapeutic hyperventilation is effective for patients with raised ICP. Those are the 3 things we need to take from this. Okay? Now, the next thing we're going to talk about is, now we have examined the brain. We want to know the distribution of blood vessels. We also want to know about the homunculus, which is just a diagrammatic representation of the areas of the brain that control the various aspects of our body. Now, you would notice that a large chunk of the brain here controls fine movements, and rightly so, because for precision movements, we need a lot of coordination from a large area of the brain, as against other movements, just as raising your leg. You can see that raising your leg here takes roughly a very small aspect, but you can see the lips and the face, you know, because these things are involved in very fine movements, you know, twitching of the face, moving the eyebrow, moving the tongue. All these things are very precision type of fine precision type of movements. It takes a very large amount of the brain. Okay, and the brain can be also categorized according to the blood supply. Now, from here, you can see that the middle cerebral artery supplies a very large chunk of the brain. So it means that if you have an injury or you have a stroke that affects the regions covered by the middle cerebral artery, a lot of things will be affected. Okay, and so you can see that the middle cerebral artery affects the arms and the face, as against the anterior cerebral artery that affects the lower limb. Okay, and it's the same thing in the sensory homunculus. The middle cerebral artery affects a very large chunk of the brain. The posterior cerebral artery affects more of the occipital lobe. Okay, it's mostly responsible for vision, as you can see here. Okay, now why is this important? Why do we need to know this? Because when patients come down with stroke, and when we are dealing with stroke syndromes, you would see that a lot of the issues that the brains affects the brain deals a lot with the vascular supply to the brain. For example, a patient who has a middle cerebral artery stroke will have paralysis of the face and the arm, and of course, the patient will also have hemiparexis, like I mentioned earlier on. But if the patient has a posterior cerebral artery stroke, the patient will have almost complete blindness. However, because the macula of the retina is supplied by both the middle cerebral artery, there will be macular sparing in a posterior cerebral artery stroke, and likewise with a middle cerebral artery stroke. Okay, this is very important for strokes, so keep this in mind when we visit strokes and we are talking about them. Okay, now there are watershed zones. So what do I mean by watershed zones? So these watershed zones are actually regions in the brain where for some very distinct reasons, ischemia affects those regions more, meaning that if there's severe hypoperfusion, that part of the brain is more critically affected than the other. And then these zones are known as the ACMA watershed zones, and the PCMCA watershed zones. Okay, and you can see them, they are highlighted here. These are the regions here. Okay, and you need to know that these regions here are supplied by the lenticular striatal arteries. Okay, and strokes that affect these regions here are very, very, very severe. Strokes that affect these regions here are very, very severe. And of course, the way God created the neurons, 4 to 5 minutes of ischemia is enough to kill the neurons. Irreversible ischemia, 4 to 5 minutes, the neurons do not get blood supply, or do not get oxygen, or do not get any nutrients. They are dead within 4 to 5 minutes, as against cardiac tissues. The cardiac tissues can survive up to 10 to 30 minutes, even without blood supply. So these watershed zones are zones you need to know for exams. They are also very common locations for metastasis. And the reason why basically is because the arteries that come here, they are not collaterals in this region. So once blood gets to that place, they are not collaterals that are able to circumvent, that deprivation of blood flow. And we need to know this. These are very important things for the exams. Now, the circle of Willis is a very interesting anatomical anastomosis. What do I need to know here for the exams? The first thing you need to know about the exams is that the internal carotid is the chief contributor of the cycle of Willis, and then the basilar artery, or rather the vertebral artery and the basilar artery, along with the internal carotid arteries, are the arteries that chiefly contribute to the circle of Willis. What does it mean? There are areas in the circle of Willis that are prone to aneurysms. And the reason why is because there's an acute angle in these regions. And these regions include the posterior communicating points and the anterior communicating points. Because of the acuteness of how they are formed, they tend to be at predisposure to aneurysms, okay? And then the posterior communicating aneurysm is quite unique in its own way because the aneurysm affects a part of the brain that is responsible for vision and the oculomotor nerve as well. So hence, these patients tend to present with oculomotor palsies. So you need to notice that's also very high yield for the exam. The next thing I'm going to talk about is the dural sinuses. The dural sinuses are large venous channels, and what happens is that this serves as a conduit for CSF production. So after CSF has circulated, it needs a conduit to be exited into, and these venous channels provide that. Okay, and then what you need to know here basically is the artery that it drains into, the internal jugular vein. Rather, sorry, the blood vessel it drains into, the internal jugular vein. This is high yield for the exams. This venous sinus thrombosis is very, very important, and why it's important is because of the presentation and the causes. This is high yield for the exam, and the symptoms, though not really high yield, although they can come out in the exam as a way to give you a cue to what the diagnoses are, but the causes are the most important thing. You must know that pregnancies, anything that causes hypercoagulability, can lead to dural venous sinuses. Okay. The ventricular system, you know, when I was mentioning about the developmental, the development of the primary vesicles, I talked about the mnemonics that I used: Kel, Deborah, Messi, Met, Miley, and each of those connections have a cavity through which the cerebrospinal fluid passes through. Okay, and they have narrow canals through which one particular ventricle is connected to the other. And the first thing you need to know is the connection between the lateral ventricle and the third ventricle. So this is also here high yield, the intraventricular foramen of Monroe, and the aqueduct of Sylvius, which is what connects the third and fourth ventricle. Now you need to know that the fourth ventricle itself forms the roof of the fourth ventricle is just adjacent to the vermis. And so patients that have agenesis of the vermis, there will be accumulation of fluid in the fourth ventricle. And this causes a syndrome known as Dandy-Walker syndrome, okay? And then, of course, the fourth ventricle drains into the subarachnoid space through the foramen of Luschka and Magendie, okay? Now, what cells are responsible for producing the CSF in the ventricles of the choroid plexus? Does anybody know that? What cells are responsible for
choroidal plexus?
Yes, choroidal plexus. But there are cells in particular that are very, very
Ependymal cells.
Ependymal cells.
Yeah, great.
Ependymal
Thanks,
cells.
guys. Yeah, great. So the ependymal cells are very important in knowing this. Okay. So this is basic anatomy. 4 cranial nerves are above the pons. So how we do this is that the first and the second one are do not have a an origin that has to do with the brain. So they come from the brain, but there's no particular part that is localized. The cranial nerve 2 comes from the diencephalon. The cranial nerve 3 arises from the midbrain. Okay, so cranial nerve 3 arises from the midbrain. Cranial nerve 4 also arises from the midbrain. But the remaining 4, meaning 5, 6, 7, and 8, arises from the pons. When we get to stroke syndromes, you guys will understand these things a lot much better. I will explain this in a more detailed fashion for you guys to understand these things, because the way you're able to identify which part of the brain is affected in a stroke syndrome, or how you're able to know whether it is lateral or medial, falls when you are able to know which part of the brain most of these cranial nerves originate from. Hence, when we get to that part, I will be able to explain that in a more detailed way for you guys. Okay. The next thing we're going to talk about is the brainstem. What do you need to know here for the exams? High yield. You need to know that the pineal gland, although not really high yield, helps with melatonin production secretion. And there's a particular tumor that's associated with the pineal gland known as a pinanoma. Okay. The pinanoma presents with vertical nystagmus. Okay, so a patient with pinanoma presents with vertical nystagmus. And the reason why is because the pineal gland just directly is close to the superior colliculi, and this is chiefly responsible for eye movements. Okay, so a tumor will affect the superior colliculi because it will enlarge and compress on both of them. The inferior colliculi, on the other hand, is responsible for auditory function. Okay, so although this is not really high yield in the exam, I will not really say people should bother much on this, but it's just good to know this. Okay, and this was what I was trying to explain, the cranial nerves and all that. So we talk about the vagal nucleus, cranial nerve 10. Why is it important? Why is the cranial nerve 10 important? Does anybody know the function of the cranial nerve 10?
It supplies heart and multiple viscera.
Yes, beautiful. So the nucleus that the vagal nucleus can be found in 3 regions. Okay, the nucleus tractus solitarius, nucleus ambiguous, and the dorsal nuclei. So these are all nuclei that are found in the vagus nerve. These are nuclei that are found in association with the vagus nerve. Okay, and they have the various functions, although not really high yield. I will not really dwell on this. What do you need to know here? These are just identification of the midbrain. There are certain syndromes that are associated with strokes of the midbrain. Okay, now when this particular part of the brain is affected, okay, this is the part that is affected by the paranoid syndrome. Paranoid syndrome is when there's an enlargement of the pineal gland and the patient presents with vertical gaze nystagmus. Okay, and then this is the cerebral aqueduct. Okay, and what does the cerebral aqueduct do? What ventricle does it connect? Which are the 2 ventricles? Which ventricles does it connect with which?
Third and fourth.
Between third and fourth ventricle, this aqueduct.
Beautiful. So the 3rd and 4th. Okay, and then this medial lemnisci serves as the 2nd order neuron for proprioception, so for vibration and touch. So this is the tract that's responsible for taking the sensation of vibration and proprioception to the brain. Okay, the red nucleus is usually affected in patients with Benedict syndrome. Benedict syndrome is a situation where the patient has ataxia, also has tremors, and then the patient has oculomotor palsy, and then the patient also has contralateral loss of vibration and touch because this part of the brain is affected. So Benedict syndrome affects this region here. It's a type of stroke. When we get to that part, you'll be able to itemize it. So this syndrome here, this region here, is the region that is affected in Benedict syndrome. This region here. Okay? That is high yield. You need to know that as well. Okay, so let's go to the next one. So this is how you identify the pons. How do you identify the pons on a CT scan? How you identify the pons on a CT scan is that The pons is the only part that has an enclosed and large, more like, how will I put it now? Has more like a pointed roof. It's more acute as against the medulla. The medulla is more curved. You can see there's a curved. This is an acute angle. This is more. How will I explain this now? The angle here is not as acute as this. So when you see this on a CT scan, you see that the space on the medulla is more than the space on the pons. Okay, so the midbrain has a lower. This is what I'm trying to say. You can see that the midbrain has a smaller cavity, and as you go down, the cavity becomes small. So the cavity between that smaller one you saw and the medulla, which is the largest, is the pons. Okay. What do you need to know here in the exams? How to identify it in the exams? You identify it with this majorly with the fourth ventricle. The fourth ventricle is where it's in the pons, and of course, like I said, the angle here is not as acute as this on the CT scan. I wish I had a picture that I've shown you guys more elaborately on the CT scan. What is the high yield thing you need to know here? Another way for you to know the medulla is that it has this structure here, which are like convolutions. They're like convolutions. This is how you know the medulla. The medulla is very distinct because it's the only one that has this among all of them. These convolutions are known as the inferior olivarial nuclei. Okay, they are convolutions. This is another way you know the medulla on a CT scan. I wish I had a CT scan. I would have shown you guys, or if there's a U-word question, I would have been able to identify it for you guys. So you can see that the other two don't have it. You can see that the midbrain doesn't have this. The pons doesn't have this as well. That convolution that you saw here, it doesn't have it. So that's how you're able to identify it on a CT scan. Now we have certain places where most of this cranial nerve originates from. Okay, so the first thing we need to know is that the olfactory nerve passes through the cribriform plate, which is located in the anterior cranial fossa. Okay, and then just below it, we have the optic canal that transmits the optic nerve, and then 3, 4, and the first part of the trigeminal nerve, as long as cranial nerve 6, passes through the superior orbital fissure or fossa, and then we have foramen rotundum that the second part of cranial nerve 5 passes through. Then we have the foramen ovale. This is very, very important. This particular foramen is very important because they usually put the question in such a way that they try to trick you. Yeah. So they might put the question in such a way that maybe a part of the brain, maybe a part of the face is affected. Maybe there's let me draw this so that you guys can have an understanding of it. So let me show you a question that I think I saw in an MBME so that you guys can have an idea of it. So they drew the face. Let me use this. So they drew the face. Is the nose. Sorry guys, my drawing is bad. So the trigeminal nerve, the V1, affects this side up to the superior orbital ridge. The V2 supplies this region here, lower part of the maxilla, and then the V3 supplies this part. So this is V3. So this is V2, and this is V1. So how the question comes basically sometimes is that they will tell you guys that okay, the patient has maybe has an injury to V3, and they might not ask you that this branch of the nerve passes through which of the following maybe foramens. They might put foramen rotundum, foramen ovale, superior orbital fissure, They might put the optic canal or something like that. So basically, you need to know which part of the trigeminal nerve passes through this. And you also need to know that the trigeminal nerve is the largest cranial nerve, while the trochlear nerve, this cranial nerve 4, is the smallest cranial nerve. Okay, and then cranial nerve 6 has the longest route because it engulfs the cranial nerve 7 nuclei. Okay, so that's just by the way. And then we need to note foramen spinosum. Foramen spinosum is the one that takes this artery, which is known as the middle meningeal artery. The internal auditory meatus is the one that carries the cranial nerve 7, that's the facial nerve, and the vestibulocochlear nerve. The other ones are much more easier to know. The jugular foramen, of course, the jugular vein, and then cranial nerve 9, 10, and 11. I don't really have a perfect mnemonics for this, but if anybody has, he can share. Does anybody have a mnemonic for that? Dr. Aman, Dr. Victoria, do you guys have any mnemonics?
I don't have any mnemonics for it.
Okay. I don't really have anything. It's just how I just remember it basically. Do we have any question at this point before I go further? Okay, so I can go ahead. Okay, so this is what I was trying to tell you. Okay, so the cranial nerves is a simple mnemonics to remember. Some say marry money, but my brother says big brain matter most. So basically, it's like a kind of college form of mnemonics that we used to remember which of them is motor, which of them is sensory, and which of them is both of them. Okay. I'm not really going to dwell on this because while we're going through neurology, we'll be able to explore a lot of this and we'll be able to explain it as we go on. Reflexes, the only thing you need to know here are the most high yield ones that I've seen in the exams, basically, is the corneal reflex, the jaw jerk, and the cough reflex and gag reflex. Those are like the most common ones. The accommodation reflex is more important when we deal with when we're dealing more with ophthalmology. When we get to that point, we'll be able to deal more with it. But I wouldn't say these things are more high yield in a way. Okay, so cranial nerve functions, the mastication muscles, of course, the muscles of mastications are all innervated by cranial nerve 5. And there's only one of them that protrudes the jaw. The other ones, they close the jaw. All the other ones protrude the jaw. It's only the lateral pterygoid muscle that that protrudes the jaw that helps to open the mouth or bring the jaw out. Spinal nerves, what you need to know, these are the high yield ones. What you need to know, and you need to know that all other nerves for the cervical cranial nerves, they exit above the vertebrae. Okay, so that's all you need to know concerning that. The spinal cord, of course, this is very, very high yield. I can't emphasize this. The spinal cord in an average adult ends at probably L1 and L2, but for children it goes lower than that basically. And then when you want to do an epidural, usually they frame this question, because I've seen it a lot in UWorld, is that they would put all these things that they mentioned, all the various what do you call it? All the various aspects that the needle passes in an arrow fashion. So they might put maybe option A, they'll write maybe the skin. So for option A, let's say this is A now. They'll not say option A, they'll put skin, you pass through the skin, then you pass through the subcute, then you pass through the fats, just like that. That's how they arrange it in the exam. But maybe in option B, they'll write maybe skin, and then they'll write maybe fats, they'll invert it, and they'll write subcute, just like that. So the most important thing is to know the order to which it comes in. You need to know that. How may I remember this basically is that Once I'm able to remember skin and fat, I remember this mnemonic. Mnemonics is sire. So this is the mnemonics I use. Sire. Sire. So the mnemonics I use is the supraspinous ligaments, the interspinous ligaments, ligamentum flavium, and then the epidural space. Because this is the most difficult part of remembering the mnemonics. Like, this is the most difficult part of actually itemizing it, because everybody can remember skin, subcutaneous, fat. Everybody can remember that. But how are the ligaments arranged? That is the most difficult part. So the mnemonics I use is SILE. So you know that S stands for supraspinous ligaments, then interspinous ligaments, ligamentum flavium. So the ligamentum flavium is more closer to the spinal cord as against the interspinous ligaments. And interspinous ligament is more closer than the supraspinous ligament. So the mnemonics I use is SILE, supraspinous, interspinous, ligamentum flavium, and then epidural space. Once you do it that way, you're able to remember it. Then the other ones are a little more easier. The dural, because this is the most difficult part of remembering it, this part here. These 4 ligaments here, they are very, very difficult. A lot of people interchange it. So people might think that interspinous comes before spinal. So when you get to that stage in the exam, you can just remember SILE, supraspinous, interspinous, ligamentum flavum, and then epidural space. Once you're able to get to that stage, the other ones you can arrange them. Okay. Now there are 2 syndromes that you must know: conus modullaris. Okay. Now there's a way to remember which the difference between both of them. A very easy way to remember it. Okay. And how you remember this basically is that conus, cauda equina itself. Cauda equina comes from so let me just get this so that you guys can understand how you'll be able to remember cauda equina. So cauda equina, how I remember it is that cauda equina is like, how many of you guys know a horse? If this is a horse, let me use this as a horse, for example. This is the 2 legs, then the hand. Then the tail. The conus medullaris is the last end of the spinal cord. So let's assume this to be conus medullaris, this side here, CM. When the spinal cord gets to this conus medullaris, what it does is that it's now kind of like differentiates into this like leaflet kind of like what do you call it now, structure, and this is known as the cauda equina. Okay, so how I remember this is that for the conus medullaris, the symptoms are usually bilateral. That's the first difference between both of them. And now, another thing that I want you guys to remember here is that because it is bilateral, it is symmetrical as well. So whatever pain the patient is having is usually symmetrical. It radiates to the leg. Both of them have radicular pain and low back pain. But low back pain is more commoner in cauda equina. Low back pain is more commoner in cauda equina as against radicular pain. Radicular pain is more commoner because it radiates to the leg. You can see this drawing here that I use the conus medullaris, right? The conus medullaris comes down. So how I remember it is that the pain radiates to the leg. But for the conus medullaris, it's more of a back pain. The patient presents with more severe back pain. So in the question, when you see a patient presents with low back pain, saddle anesthesia, perianal, loss of anal cutaneous reflex, and the question tells you that the patient has a more severe back pain, you are more tilted towards going to cauda equina, as against when they tell you that the patient has a more severe pain that radiates to the leg. The symptoms is more bilateral, and then you have other symptoms, loss of anal cutaneous reflex, saddle anesthesia, you'll be tilting towards more of conus medullaris. So that's how you're able to differentiate it in the exam, because it's very confusing and a lot of people tend to mistake it in the
Can
exam.
you repeat it, please? Can you repeat it? These two?
Okay, let me repeat it again. So what I do is that anytime I'm faced with a question with cauda equina or conus medullaris, what I do basically, the first thing I do is that on my question paper or my U-word or whatever, I draw a horse. This is like a horse. I'm sorry, guys. This is very ugly. This is a very ugly horse. And what I do is that the back of the horse, this part here, I call it my conus medullaris. The conus medullaris is like the terminal end of the spinal cord. So when the spinal cord gets to L1 and L2, the point where it starts forming this leaflet, that branch that it starts forming this leaflet is known as the conus medullaris. This point here. This point here. So the point where this thing now branches and form here, this point here, is my conus medullaris. But what I do in the exam is that I draw the legs of the horse. I draw it down. So by drawing this leg down, it means that conus medullaris, the patient with conus medullaris has more radiculopathy. It has more pains that radiate to the leg. So the patient presents with severe pains that radiate to the leg. But as against cauda equina, how I remember it is that the tail of a horse, the tail of a horse is just the horse has only one tail. So it means that the radicular pain is usually asymmetric. And it's not as severe as the one that the patient with conus medullaris has. So what I do in my mind, I'm just trying to tell you how I'm able to address the question and make it a lot more easier. I make the concept a lot more easier, is that when I draw the horse, I remember that the patient with conus medullaris has a more severe pain, because you can see from the horse, this point at this junction, it comes down. So it means that the pain radiates to the leg. But for cauda equina, the patient has more severe back pain. So that's how you're able to differentiate it, first of all. And then second of all, I just remember that since the horse has two legs and one tail, it means that conus medullaris affects the both legs. So it is bilateral. But because the horse has one tail, it means that the cauda equina will affect only one limb. Do you guys understand what I'm trying to say here?
Yep.
Okay. So that's how I'm able to remember it. Although there are other symptoms that come with it, such as the saddle anesthesia, bowel dysfunction, all those other things. But the most important thing you need to know, are two things. That conus medullaris, or rather three things. Let me differentiate it in three ways. Conus medullaris affects two limbs. So it is bilateral, it is symmetric. The patient presents with severe radicular pain. That means radicular pain, meaning that the pain that the patient undergoes is more severe when it radiates to the legs, as against cauda equina. Cauda equina, the patient has severe back pain, and it is asymmetrical with lower motor neuron symptoms. Can I go over it again so you can understand what I'm trying to say? The difference between both of them is this. For conus medullaris, you draw a horse. When you draw a horse, remember that the point where the tail of the horse comes out is the conus medullaris. And then the conus medullaris extends to the leg. What does that tell you? It tells you that conus medullaris affects bilateral limbs, meaning that it is symmetrical, not unilateral, as against cauda equina. Secondly, it tells you that this patient that has this thing, the pain that affects the patient is bilateral and it's radicular, meaning radicular, it spreads down the limb, as against cauda equina that just has very low back pain, severe low back pain. The other difference is that conus medullaris is an upper motor neuron lesion, as against cauda equina that is lower motor neuron lesion. When you are able to know these three distinguishing features, when you answer a question on U-word, you will not miss it. When you are able to know these three differentiating things I just mentioned, when you answer a question on UWorld, you will not miss it at all. When you know that conus medullaris, okay, does the patient have severe low back pain? Is the pain severe? Because usually they will tell you in the question. They will state it in the question that, oh, the patient has severe, or if you don't see the word severe, they'll just tell you low back pain. Or sometimes they might not tell you severe. They might tell you that the patient has a low back pain that radiates to the leg that prevents the patient from walking. They might put it that way. So it's up to you to be able to identify what they are trying to say. Or sometimes they might put it.
Conus medullaris.
Yes, for conus medullaris, yes. They will tell you that it goes to the leg and it is very severe for conus medullaris. But for cauda equina, they might tell you that the patient has radiculopathy to the leg. However, the patient has severe lower back pain. They will stop there. So they are trying to tell you that is cauda equina. They might not tell you that, oh, the patient has weakness of the leg. The patient has weakness of the leg. So they are trying to tell you, they might tell you that, oh, the patient might have stiffness of the leg. Stiffness. Now you can see that the difference between weakness and stiffness is different. The stiffness is more in line with an upper motor neuron lesion. They're trying to tell you that the patient has spastic weakness. As against when they just tell you ordinarily, the patient just has weakness. So there are clues in the questions that you'll be able to identify the answer with. And the most important thing among all of them is that sometimes they will tell you that the pain in cauda equina radiates to only one limb. When they tell you that it radiates to only one limb, you know that it is cauda equina. When they tell you that it goes to both limbs, the two limbs are affected, you know that it's conus medullaris. These are little things from the question you can be able to use to differentiate your answers. Do you guys understand the concept?
Yes.
Okay.
I missed the important part of this conversation. Are you able to take it one last time for me, please?
Yes, I can, of course. Okay. So I was trying to highlight earlier on that anytime I see a question on cauda equina or conus medullaris, the first thing I do, I get a piece of paper. And in that piece of paper, what I do is that I draw a horse. Sorry, this is a horse. I'm sorry. I'm not a very good artist, so you have to bear with me. So I draw a horse, right? And then when I draw the horse, I label the horse. How do I label the horse? The point where this tail comes off, right? Where this tail comes off is the conus medullaris. It is the lower end of the spinal cord. Okay? And then when this tail comes off, I now draw a straight line that comes down, meaning that most likely the patient with conus medullaris will have a radiculopathy, meaning he will have a lower back pain that is not so severe, but the pain that the patient has on the legs are more severe, and the pain radiates to the legs, and the radiation is more severe. That's how I remember it, first of all. And then what I now do is that the second way I remember it is that this leg that I'm seeing, a horse has two legs, but has one tail. Meaning that if the patient has a symptom that is affecting the patient, and the patient has cauda equina, the patient will have only one limb that is affected, one lower limb will be affected. Which is why the horse has one tail but has two legs. So the two legs represent bilateral involvement for conus medullaris. Meanwhile, the one tail represents unilateral involvement for cauda equina. That's the first cue in the question. So when I see the question, for example, the patient has perianal anesthesia, saddle anesthesia, or a loss of anocutaneous reflex, bowel dysfunction, and the patient has lower back pain that severely radiates to the leg, or radiates to the leg to the point that the patient is not able to walk or cannot tolerate the pain. When you see that word, the patient is not able to tolerate the pain and it radiates to the leg. The pain that radiates to the leg, the patient is not able to tolerate it. That gives you an insight that, oh, this is conus medullaris. But when they want to frame the question for cauda equina, how they put it is that they will tell you that the patient has severe low back pain. They will put that word severe, or they will tell you disturbing low back pain that radiates to the leg. They won't tell you that the pain that radiates to the leg is severe. They won't tell you in the question. They will just say the pain is severe in the lower back. That's what they will tell you. When you see that the pain is severe in the back, it does not it radiates to the leg, but it's not as severe as the one in the back. You are thinking more of cauda equina. Okay? And then the last thing you need to know about both of them, which is why I highlighted this, is that anytime you are stuck in the exam, just remember, the mnemonics I used to remember it as, a horse has one tail, but has two legs. So the one tail, the word cauda equina, equina comes from a horse. That word equina comes from a horse. The cauda means tail. Anytime you see cauda, cauda means tail. Cauda is gotten from the word caudal, caudal. And caudal means the tail, the end, the back. So anytime you remember cauda equina, just remember the horse's tail. And when you're able to remember, the next thing I want you to remember is that the horse has one tail, but has two legs. Once you're able to remember these two things, you'll be able to differentiate, okay, this patient, is it two limbs that is being affected or it's one limb? And then the next thing you need to ask yourself is that the pain, is there more severe pain that goes to the leg, or is it only just localized to the back? Is the pain that is severe, is it at the back alone, or is the pain that radiates to the leg is severe? That is the next question you need to ask yourself. Then the third question you have to ask yourself is that, is it a bilateral involvement? Are two legs involved or just one leg? If two legs are involved, it's telling you more of conus medullaris. And sometimes they might tell you that, oh, the patient has weakness of the lower limb. If they just state weakness, it is tilting more towards cauda equina because it's a lower motor neuron lesion. But if they now say, oh, the patient has weakness and sometimes the patient finds it difficult to move the leg, they're not telling you that the patient has more of stiffness as against weakness. So if the patient has more of stiffness or spastic weakness, you are thinking more of conus medullaris. Do you understand what I'm trying to say here? Are you getting the way I'm able to?
Yes, yes.
Yes, yes, making sense.
Yeah,
Yes.
good.
Yes.
All right.
Thank you so much.
All right. So let's move ahead. The next thing we're going to talk about is the spinal cord. The organization of the spinal cord. So basically, so this mnemonics is important, although I won't really dwell on this because it's not really high. The only thing you need to know is when we get to cuneus, gracilis, and gracilis and
Cutaneous, yes.
yes, cuneus, yes. Yes, so that's where this thing is very important. So the one that is outside, the arms that are outside, I think I don't know if you guys can correct me if I'm wrong. I think the cuneate is for the arms and the gracilis are for the legs. Am I correct, guys? I don't really know.
Yes.
Yes, it's correct.
Yeah.
That's
So
right.
how I was able to remember, it's been a long time that I actually remembered. How I was able to remember it is that for gracilis, there's a G in legs. G in legs. So how I'm able to remember it is that the G, I just remember the G to mean gracilis. So I just remember that, oh, gracilis is the one that is inside, and then cuneate is the one that is outside. The legs are inside, the arms are outside. And you can actually relate it. When you stand physically, your hands tend to, go to the side, tend to be outside, tend to be more exterior than your legs. Your legs tend to stay more medial when you stand. So another way I remember it is that when I stand, my hands tend to go outward as against my legs. My legs are more in the middle. And of course, the G stands for gracilis. So that's how I'm able to kind of like tie it to make it a little more, easy. So this part that is closer to the middle, okay, would stand for the gracilis. And this part that is outside here will stand for the cuneatus, right? Meaning that the cuneatus helps with the arms, and that is outside, while the gracilis stands for the legs and is inside. It's just a way to just remember it, to make it very easy for you to remember in the exams, okay? Can we go to the next slide? Okay, yes. So tracts. What do I need to know here? Basically, what are the functions of each tract? That's the first thing I need to know. Pain, temperature, pressure, vibration, voluntary actions. Okay? These are the first things I need to know. What is the function of the spinal thalamic tract? Okay, it helps to modulate pain and temperature. Okay, what about the dorsal column? The dorsal column helps to modulate pressure and vibration. What are the corticospinal tracts responsible for movement? They don't usually ask you in the exam what the first order neuron are, but what they do ask you is usually the first synapse. So if we look at this, basically, let's go to this diagram. For the spinal thalamic tract, you can see that it enters at the same spinal cord level and decussates at the same spinal level. The same thing with the what do you call it now? With the corticospinal tract. The only difference is the what do you call the dorsal column, right? It enters at the same level, but decussates at the medulla, at the dorsal column nuclei, and you know. So what you need to know basically is the second order neurons. That is the most important thing. The synapses rather, not the second order neurons, and where it decussates. Okay. Those are the most important thing you need to know here in this particular synapse. And of course, it comes out a lot in the exams. You need to know that. You don't need to know the other neurons. Those are not what you need to know. You need to know where its synapse is. That is what you need to know for the exams. You don't need to know which other neuron comes first. Those are not what you need to know. Okay? They will only ask you in the exam, where does it decussate, or what is the second order neuron? That's basically what they'll ask you. Or they might tell you, where does it pass through? Does it pass through the thalamus, or does it not pass through the thalamus? Those are key things you need to know in the exams. So I will not really dwell so much on this. Okay? Spinal reflexes, very easy to remember. S1, S2, buckle my shoe. This is a very simple mnemonics that I think a lot of us we know here. I would say in the exam, the two reflexes you need to know for the exam purposes are these. These are the two reflexes that are very, very important, and you need to know the spinal, the dermatomes that's affected. So the cremasteric reflex is L1, L2. Okay, and then the anal weak reflex is the X3, X4. Okay. I think those are the most important things you need to know here. You have to know this. These are very, very high yield for the exams. The primitive reflex, the ones you need to know. So there's a mnemonics I used to remember this. Let me just write it for you guys. Very, very sweet mnemonics. Okay, so let me just write it to you guys so that you can see. The mnemonics I used to remember the, especially when you are preparing for step 2, it's very, very important that you know these reflexes, especially for pediatrics. So the mnemonics I remember is Mrs. Palmer. If you guys watch football, you know that there's a guy called Cole Palmer. Plants grapes. Okay, so these are the mnemonics I used to remember. Moro routine sucking. So for Moro reflex, what you do is that you pick up the infant, and when you pick up the infant, you should do as if you want to drop the infant. The infant spreads his hands and brings his hands back and then starts crying. That's Moro reflex. Usually, these reflexes are supposed to, especially for Moro reflex, it's supposed to, the baby is supposed to stop having this primitive Moro reflex in particular by the age of 1. And usually in others, in disorders of the frontal lobe, there's a re-emergence of most of these reflexes. Okay, because the frontal lobe is the one that inhibits most of these reflexes. So by the age of 1, you expect, I told you guys that there's maximum brain development between the first 2 years of life. So basically, as the brain starts developing, especially the frontal lobe, because the frontal lobe is responsible for executive functioning, is responsible for behavioral judgment, thinking, and all that. So as the frontal lobe is developing, you would expect that it becomes more stronger and it inhibits most of this primitive reflex. So the mnemonics I remember is Mrs. Palmer plants grapes. Okay, so Moro is for the M, R is for the rooting reflex, S is for the sucking reflex. The rooting reflex basically is that you put your hand on the side of the baby's mouth and you just move it a little, and then the baby turns towards where that stimuli is coming from. The sucking reflex is something that you check for newborns. When you put your hand in their mouth, you notice that they grab your hand and try to mimic how they suckle for breast milk. The palmar reflex is just when you put your hand on the baby's palm, grabs your hand, doesn't let it go. The plantar reflex, this is the one that is quite dicey, and the plantar reflex is more like you dorsiflex. This is the one known as Babinski, okay? Babinski reflex. So ideally, what happens in Babinski reflex is that this is the leg. Let me use this to draw. So this is the leg. So let's assume this is the leg, right? Okay. And then what happens is that this is the big toe. So when you stroke the sole of the baby's foot, the normal response is that all these fingers will plantar flex. Plantar flex. That is normal Babinski reflex or normal plantar reflex. The opposite happens for abnormal Babinski reflex, which can also check in patients that have upper motor neuron lesions. Can you guys give me a minute? I'm coming. Let me just give me a minute, please. Just give me a minute. Okay, so I'm back. So now the plantar reflex, what you have there is that when you stroke the sole of the feet, this is the only one that will not plantar flex. So the big toe will dorsiflex and the rest of the leg will plantar flex. Okay? Let me go over it again. The normal response for a plantar reflex is that when you stroke the sole of the foot, all the toes or digits of the feet will plantar flex. But when you in abnormal Babinski reflex, when you stroke the sole of the feet, the big toe will dorsiflex, that means to go backward, but the remaining digits will plantar flex. Okay? You guys understand that?
Yes.
All right. So let's move ahead. So dermatomes, okay? So they're important in identifying especially when you have all these cranial what do you call it now? When you have patients that have maybe, for example, a radiculopathy that is affecting the body. So you can see that the posterior half of the skull is C2 at the back here. And then turtleneck, this region here is C3. And then C4 contain, of course, is responsible for the diaphragm. C4 is the lower collar, the collarbone. That's where C4 is. C5 is the thumb. So let me draw this so that you guys can see what I'm talking about. So this is the thumb. Okay. So this region here is C6. This region here, C7. And the underneath region here, this remaining region here, C8. So you can actually tell, although all these things have their own part in muscle innervation, but we'll get to that when maybe we are talking about maybe we're answering you all questions or so. You'll be able to understand those parts better. So T10 is at level at the umbilicus. T7 is xiphoid process. L1 is at the inguinal ligament. This is high yield. L4 is at the kneecap, also very high yield. You need to know this. Then this region here, these are high yield regions that you need to know. Okay, so we're at pathology. I don't know if you guys want us to go ahead.
Hello,
Or should
Dr.
we
Ohis. Hello.
Hello, Dr. Ahmed.
Yes, Dr. Ohis, I think it would be enough for today. A lot of
Okay.
students have to revise it as well. Really sorry, I'm just out. Okay, so we should just continue our session tomorrow. Okay.
Okay, great. So
Okay.
we're
Thank you
entering
so much
pathology.
for having such an amazing session. Thank you.
All right. You're welcome, guys.
Thank you.
Thank you.
Yeah.
Okay, thank you. Thank you.
I hope there are
Thank
no.
you so much.
Are there any
Dr.
questions? Are there any questions?
We'll definitely save them up for tomorrow.
All right then.
For tomorrow. Thank you.
No problem.
All right.